So the motivation was kind of taking a step back and thinking through, where have our successes come from? In other words, our on average, very effective treatments like DBS for tremor, DBS for Parkinson's disease, where did these treatments come from, and what was our pathway that led to these successes? And can we emulate or improve on that pathway to develop new DBS targets for new symptoms? And there's a lot of different research approaches to identify therapeutic targets, all the way from cell work to mouse work to primate model work to neuroimaging in symptomatic patients. And there's no shortage of research techniques to try and identify these therapeutic targets. But when we looked at different research methods in the past and which research methods have actually led to successful therapeutic targets, one of the methods that really seemed to stand out was lesion studies in human patients. I've had people argue, and I think there's value to that argument, that most of what we know about mapping out human brain function actually came from lesion patients. In other words, we know that the hippocampus is involved in memory, not because monkey studies told us that, or rat studies told us that, or functional neuroimaging of memory told us that. We know that because patient HM had his bilateral hippocampi chopped out and couldn't make new memories. And there are many, many cases like this where these lesion studies gave us critical information that's held up over time about what maps where in the human brain. And some of these lesion studies have led to successful therapeutic targets. And so our DBS targets literally came from somebody going through and creating iatrogenic lesions in different parts of the nervous system until they found a spot that had a symptomatic benefit without horrible side effects. Now, what we'd like to avoid is this trial and error approach of iatrogenic lesions, where you just literally go in and lesion different spots until you get a win. And so we said, okay, can we leverage patients with strokes with spontaneous lesions that had interesting therapeutic effects? Maybe the lesion got rid of tremor, or maybe the lesion got rid of depression, or maybe the lesion caused depression. And do these lesions allow us to map out the circuits that are causally involved in these different symptoms? And maybe that can lead to therapeutic targets in a way that's more efficient than just going in and creating lesions in patients in different spots, and a way that has a stronger causal link to therapeutic targets than going in and looking at imaging correlates of these different symptoms that we're trying to treat. And so that was the motivation to go back and focus on these old lesion cases, but then bring a new twist to it. So when you go back and focus on these old lesion cases, one of the things that becomes difficult is a lot of these lesions that we're most interested in don't line up. In other words, they don't hit one specific location that makes our therapeutic target super obvious. They hit lots of different locations in the brain. And so one of the perspectives we brought to this was to say, okay, we've spent many, not just decades, but centuries trying to map out lesions to individual brain regions. Well, for the first time, we now have a wiring diagram of the human brain called the human connectome. Maybe we can use that to map these different lesion locations onto brain circuits. And maybe that's a more effective way to maximize the value of these lesion cases. So we've looked at a lot of different neurological and psychiatric symptoms, but one of the ones of greatest interest to movement disorders clinicians and of high relevance for DBS is Parkinsonism. So Parkinsonism just means the symptoms of Parkinson's disease. Now, most people get Parkinsonism from idiopathic Parkinson's disease. They have degeneration of neurons in the substantia nigra, and that's where you see the stiffness, the slow gait, the tremor coming from. However, there are cases of people that had a stroke in just the right location that ended up causing the symptoms of Parkinson's disease. Again, those cases are rare, but they're uniquely valuable because every one of those patients, we have a causal link between damage to a specific location in the brain and the symptoms of Parkinson's disease. And so when we mapped out all these different lesion locations, first things first, we did not see the lesions all lining up on one brain region. It wasn't like every one of these strokes hit the substantia nigra. The strokes could be cortical, they could be subcortical, they could be in a lot of different brain locations. We then took these heterogeneous lesion locations and overlaid them on a wiring diagram of the human brain to say, okay, we know these lesions aren't all hitting one brain region. Are they all hitting one connected brain circuit? And what we found is that yes, they were. And it was specific to lesions causing Parkinsonism compared to lesions causing lots of other things. But the hub of that circuit was surprising. We thought maybe it would be the substantia nigra. That's what we think about in Parkinson's disease, but it wasn't. It was actually in the claustrum. So all these different lesion locations were all part of one brain circuit defined by connectivity to the claustrum. And again, we scratched our heads and thought, gee, that doesn't make a whole lot of sense. Nobody knows anything about the claustrum, and certainly that's not an area that people talk about as a hub of Parkinson's. But it did line up with these lesions, and it did line up with several other things that were interesting. So once we knew the circuit and we could look at this claustrum connectivity profile, it did line up with all these lesions, but it also lined up with atrophy patterns in patients with Parkinson's disease, atrophy patterns in patients with atypical forms of Parkinson's, so multiple systems atrophy, progressive supranuclear palsy, and then finally with therapeutic targets. Nobody's ever gotten a DBS electrode to the claustrum, but people have gotten lots of DBS electrodes to the subthalamic nucleus. And so we just looked at, does connectivity from their DBS electrode to the claustrum covary with their symptom improvement? And again, the answer was yes. And so this is all very circumstantial evidence, right? This is all retrospective, trying to make sense of existing data. But it did say that there might be something to this claustrum is a seat of Parkinsonism, even while the substantia nigra might be the seat of idiopathic Parkinson's disease. And the reason it's exciting to us is that we're pretty good at treating the symptoms of idiopathic Parkinson's disease by replacing dopamine or by doing DBS to the subthalamic nucleus or the globus pallidus. We're actually really bad at treating Parkinsonism. So people with MSA or progressive supranuclear palsy or lesion-induced Parkinsonism, their replacing dopamine doesn't tend to work. And DBS to the subthalamic nucleus and globus pallidus doesn't tend to work. So is there a treatment target for Parkinsonism that's different than our therapeutic target for idiopathic Parkinson's disease due to lost dopamine? I'd say we're generating new hypotheses, right? So, and I want to really emphasize the limitations, especially when speaking to clinical neurologists or movement disorder clinicians, because it's very tempting to take some of these new research findings and immediately say, I know what I'm going to do to treat my patient tomorrow. And I do not advocate anybody, sticking DBS electrodes into the claustrum to treat multiple systems atrophy. Right? That would be a misinterpretation or an overinterpretation of our findings. What I do advocate for is the next step in research to say, all right, could this claustrum be a therapeutic target? Could this make sense? And how do we begin to explore this? How do we research this in animal models? How do we begin to look at human data and see if this might line up? And so I think it's an important question for future research. And in fact, I wouldn't be adverse to targeting the claustrum based on DBS reprogramming, where you hit connections that are more connected to the claustrum. And I wouldn't even object to a DBS trial as part of a clinical research study. But I do want to make sure that clinicians don't overinterpret these findings, beyond what the data show. It's all retrospective, and we have yet to confirm any of these things prospectively.